Again, my name is Erin Ficker, and welcome. We will get started as it is now the top of the hour. My name again, Erin Ficker, one more time. I'm one of the co-managers of the Child Safety Learning Collaborative and the Sudden Unexpected Infant Death Prevention Topic Team Lead. I'm excited to be here with you moderating this webinar and to be joined by my colleagues. Excuse me, this project is supported by the Health Resources and Services Administration, or HRSA, under a cooperative agreement. The information and content and conclusions of those are both the author and should not be construed as the official position or policy, nor endorsements should be inferred by HRSA, HHS, or the U.S. government. I'm going to turn it over to my colleague Kate to run us through some quick technical tips.
Thanks, Erin. Welcome, everyone. If you can hear me right now, you've noticed that the audio is being broadcast through your computer speaker. If at any point you're having audio issues, please go ahead and dial in at 866-835-7973 and remember to mute your computer speakers. You will be muted for this webinar since there are so many of you joining on this great conversation today, but please go ahead and put any questions or thoughts you may have on the chat to the left-hand side. Today's slides are available for download in the file share pod at the top of the screen. And this session is being recorded, and all of our participants will be sent the recording links within a week of the webinar. Back to you, Erin.
Thanks so much, Kate. And again, if you missed that phone number, it is in the upper left-hand corner of your screen if you need to call, and it's also on the screen. If you can't hear me, you wouldn't know that. Our presenters today are my fellow co-managers and our CSLC lead. So Maria Catratis, who is our suicide and self-harm prevention topic team lead, will be joining us, as well as Jenny Stern-Carasone, who is the associate director of the Child Safety Network and the CSLC lead. So they will be walking us through some of this information and joining in the conversation. I do invite you to join in the conversation as we do have a chat open. And in that chat, if you have questions or want to share your own experience using quality improvement tools or as part of the CSLC, we would love to have you enrich this with your voice. So moving on. On our agenda today, we will be talking about the Child Safety Learning Collaborative with overview and highlights from Jenny. We'll then move on to talking about the CSLC quality improvement tools that we use and that we highlight with our teams. And then we'll hear from the voices from the field. We have three fabulous teams joining us today to talk about their experience using these tools in their work and how they have helped improve how it has helped improve their work. And then we'll have a period of question and answer at the end. So without further ado, I want to turn it over to Jenny Stern-Carasone, who's going to talk us through an overview and some highlights of the Child Safety Learning Collaborative. Jenny?
Thank you so much, Erin. Welcome, everyone. It's wonderful to see so many people joining us to hear about the work that's been going on in the Child Safety Learning Collaborative. So as I get started, I just want to tell you a little bit about the CSLC, as Child Safety Learning Collaborative is obviously a very long name. The Children's Safety Network is HRSA's primary vehicle for providing training and technical support to all Title V agencies. And our vision at CSN is for all infants, children, and adolescents to be safe and healthy with nurturing, safe relationships, and safe environments. We seek to achieve this by working with our national alliance called the Children's Safety Now Alliance, which is comprised of federal, state, community-based, and university partners, and also our Child Safety Learning Collaborative, as I said, referred to as the CSLC. As you see here, the CSLC vision mirrors what the CSN vision and goals are as well. The CSLC is a unique opportunity for state and jurisdiction Title V agencies to be able to collaborate with one another directly with the aim to advance evidence-based policies, programs, and practices at the state and local levels to reduce fatal and serious injuries among infants, children, and adolescents ages 0 to 19. To achieve the CSLC vision, we utilize the CSN Framework for Quality Improvement and Innovation in Child Safety. You can find this resource on our website. The framework draws on elements of the CDC social ecological model, the Foundation Strategy Group's collective impact approach, the Institute for Healthcare Improvement Breakthrough Series, and the Associates in Process Improvements Model for Improvement. The focus of the framework is to support states to be able to make improvements and innovations in their child safety systems and their workforce development, which we then believe will lead states to having greater positive health impact in the populations that they serve. Of course, health equity underpins all of this work in the entire framework, enabling states to effectively use data to understand their target populations and to identify which areas they want to focus on. In order to build public will and state jurisdiction capacity in key areas essential to achieving sustainable and scalable child safety results, the CSLC targets the following core tenets of the framework: the identification and use of data-driven, evidence-based, and evidence-informed strategies and programs to enhance child safety expertise, increased effectiveness of management and leadership, and systems improvement through ongoing commitment to shared learning principles drawn from advances in improvement and implementation sciences. The CSLC enables Children's Safety Network to tailor our work to injury topics identified as having the highest rates of injury and where we see the greatest opportunity for improvement, as well as being able to truly meet states where they are at by providing targeted training and technical assistance specific to their current needs. The CSLC topic areas were selected based on analysis of child safety data trends and alignment with maternal and child health national performance measures. Prior to the launch of each cohort, states and jurisdictions applied to join the CSLC and then were asked to select one or two of the topic areas to work on in each cohort. The design of the CSLC draws on the Model for Improvement from the Institute for Healthcare Improvement and utilizes a quality improvement approach, which you'll hear much more about in the pursuing slides. Each participating state or jurisdiction is guided to form a strategy team of their design to lead their injury prevention efforts in each of the selected topic areas that they're choosing to work on. And then they participate in regular CSLC activities, which include bi-monthly topic calls with all the other state strategy teams that are addressing that topic, reporting monthly data, and participating in CSLC-wide learning sessions that occur 1 to 2 times each cohort. Teams then also have access to unique tools and resources and targeted technical assistance to help them to further pursue their work. On this slide, you can see the 23 states and 1 jurisdiction we've had participating over the course of the CSLC. Current teams in Cohort 3 are addressing the 4 key injury topics you see on the screen: bullying prevention, motor vehicle traffic safety, sudden unexpected infant death prevention, and suicide and self-harm prevention. Additionally, in Cohort 1, we also had some teams that were addressing poisoning prevention. The CSLC was launched in November of 2018 and consists of 3 cohorts over a 5-year period, each cohort lasting approximately 18 months. Many teams have continued on into successive cohorts. When we launched the 3rd and final cohort of the CSLC in November of 2021, we had 11 of the 14 Cohort 2 participating states opt to continue on into Cohort 3, some of them having even been in Cohort 1, and we also welcomed the addition of 2 new states. Some of these teams, as I said, also are addressing multiple topics. CSNC's objective in launching the CSLC, as I described, is to accelerate our potential for states and jurisdictions to reduce hospitalizations, emergency department visits, and fatalities for children and adolescents. While each participating team is setting their own goals and objectives to work on and achieve over the course of their participation, CSN is collecting and analyzing data over the course of the entire 5-year CSLC in order to measure the impact of the Learning Collaborative. Drawing on national data sets, our partners at the Pacific Institute of Research and Evaluation helped to define the following objectives that we are seeking to achieve by the end of the 5-year period. These objectives align with the national performance measures 5, 7, and 9. In addition to analysis of national data, CSN asks that strategy team leads for each of the teams that states are working with complete a brief questionnaire at the start and the completion of each cohort they're participating in to help us better understand the change over time in each of the outcome areas of workforce development and improved child safety systems. So at this point in our CSLC journey, we are able to look back over the first 2 cohorts and are starting to be able to assess and evaluate the impact of the Learning Collaborative and the evidence-based and evidence-informed strategies that are being utilized. As a reminder, as I noted earlier, in addition to the 4 current key injury topics, teams in Cohort 1 also were addressing poisoning prevention strategies. So as you can see here, from the statistical information on the screen, we have seen significant progress in every topic in the first cohort. In the poisoning prevention team, over 6,000 individuals have reported to have received education on poison control center services. In bullying prevention, while the total number of reported schools and organizations that are implementing evidence-based bullying prevention programs is only 5, this is a 400% increase from the baseline number. This is a prime example of how quality improvement is not always about big numbers, but really about big improvements. Within the motor vehicle traffic safety team, those teams that have been working on child passenger safety in Cohort 1 had over 600 child passenger safety technicians trained and certified during the cohort, and 11 organizations that offered child passenger safety education to parents and caregivers, which was an increase of 175% from their baseline. Similarly, there was a 59% increase in schools providing teen driver safety education to teams during this cohort. Moving on, looking at our other topics, in sudden unexpected infant death prevention, during Cohort 1, we had 241 hospitals or birthing facilities that were reported to be providing safe sleep training to healthcare providers. Additionally, we had a reported 41% increase of home visiting programs distributing safe sleep educational materials and a 56% increase of organizations implementing and spreading evidence-based safe sleep campaigns. The dramatic results that we've seen in the work of Cohort 1 suicide and self-harm prevention teams include a 400% increase in organizations providing zero suicide, a 300% increase of schools or organizations providing multi-component prevention programs, and over 200 schools and organizations providing gatekeeper training. Again, these results are from Cohort 1 and represent data that was collected across the entire CSLC from all teams participating in each of the topics. Given the recent conclusion of Cohort 2, only in November of 2021, we haven't yet had the opportunity to review and analyze the impact data as we have for Cohort 1. But still, there's a lot of significant progress that we are able to celebrate as teams have shown exemplary resilience and continuing commitment to child safety despite the fact that this cohort occurred during a global pandemic and a time of great disruption. Here are some examples of how teams sustained the gains, pivoted to new ways of conducting business, rebuilt and revived partnerships, and accomplished great things over the 18-month period. In bullying prevention, teams have worked to adapt an evidence-based bullying prevention program for schools to be used in an out-of-school setting. They also adapted in-person training to virtual and developed peer-led trainings for the workplace. Motor vehicle traffic safety during this period saw a tremendous amount of their work translated to the virtual realm, including technician trainings, car seat installation education and checks, and even teen driver safety driver education. Without the interpersonal contact opportunities, teams had to innovate a variety of creative ways to implement and spread their messaging. This included teen-inspired campaigns on TikTok and Instagram, thus enabling partners to readily leverage the wide variety of social media platforms to share information and all sorts of handout materials that further promoted their motor vehicle traffic safety work. Like the other topic areas, suicide prevention was also translated much of the work into the virtual realm during the Cohort 2 period. This included trainings for home visitors, as well as using technology to extend their reach to hospitals statewide. Teams also leveraged partners to increase their reach, including strengthening partnerships between maternal and child health programs and working with county-level public health. They also built off their own CSLC experience, creating local networks to share and promote the use and application of quality improvement in their work. And the Suicide and Self-Harm Prevention Team in Cohort 2 have kept this essential child safety topic at the forefront of injury prevention work throughout the cohort, with gains including development of a mental health toolkit for parents and caregivers of students in crisis, and a comprehensive resource guide to be distributed statewide. Teams also focused on increasing awareness of COVID-19 effects on child and adolescent mental health and increasing cross-sector partnerships and cooperation to effectively address this issue. Now I'd like to hand this off to my colleague and topic lead for the Suicide and Self-Harm Prevention topic, Maria Cotratis, to share more details of the tools that have been used throughout the CSLC to help that serve as the underpinning for these successful results.
Thank you so much for that great overview, Jenny. So one of the approaches that we leverage in the CSN framework is the model for improvement, as Jenny mentioned earlier, which is a tool for accelerating organizational improvement. The model centers on clarifying the aim, who we are, what are we trying to accomplish, and determining the changes you think will result in an improvement, and what data you will collect and analyze to know that the change is actually an improvement, and not just a change in circumstances. The Plan, Do, Study, Act cycle serves as the primary tool to conduct small tests of change to effectively try new child safety approaches and interventions throughout the system and adapt them to ensure they are working before implementing them system-wide. In the next slides, you'll learn about key resources that we use throughout the cohort that captures these three questions from the model of improvement, specifically our change packages and how we use the tools across the cohort. So we want to emphasize that these are not standalone tools. They're all interrelated in an iterative process that we've tried to capture in this image here. Your team's overarching aim for your system will guide the development of the quality improvement journey that you're on. Components of your overarching aim can be broken down into 90-day aims, and to achieve those aims, you should run PDSAs. The learning from each step will inform future PDSAs, 90-day aims, spread planners, and the overarching aim for your work. In the CSLC, we also have monthly reports where the states are able to indicate their monthly progress towards their strategies. This is an iterative process and by no means linear. So all of the learning that occurs under the overarching aim should then be filtered back into thinking about the overarching aim. Here we have a number of our quality improvement tools that we use in the CSLC. On the left, you'll see that we have a change package, and I'll be describing all of these in a bit. We have a change package, operationalizing form, stakeholder analysis, 90-day aim, PDSA cycles, spread planners, and health equity planner. And these, of course, are also not linear. So as I just mentioned, the improvement process is not a linear process. So you may have to respond to something, go into the field, learn something more, and then come back and revisit what you've already done. So we'll start off with our change package. This is the first step in the improvement process, selecting the strategies that you'll use to reach your desired outcomes. The CSLC members are provided with extensively researched change packages that provide a list of evidence-based strategies identified to help individual states meet their goals, as well as the topic team as a whole. And we do have some links to our public change packages that you can see from our previous work in the COIN. We have change packages and outcome measure worksheets. These are topic-specific change packages, so we have a change package for each of our topics. Next is the 90-day aim, And this helps to break down the sometimes overwhelming task of improvement. So we have these overarching aims for our work, but the 90-day aims help break down that overarching aim into bite-sized pieces that you, your team, and your partners can accomplish and celebrate along the way. They help protect against scope creep, but also ensure that your work is tied back to your original aim. Our next tool is the operationalizing form. And this form helps to take your strategy and make it your own. So as I shared, we do provide change packages that include all of these well-researched and evidence-based and evidence-informed strategies. So you will consider how to define your strategy in detail and how it will work in your setting or in your state. It will also help you define what success looks like in your setting. So most importantly, the form gives you the opportunity to provide a detailed explanation of how your state will measure and track the data related to your strategy. The next is the Plan, Do, Study, Act cycle, which I mentioned earlier. These are used for small tests of change, and they may be used in a sequence or at the same time. And they can also be used for process and program-related changes. So the ultimate goal of the Plan, Do, Study, Act cycle is to determine whether a change should be adopted, or abandoned. And in order to do that, you need to identify your potential partners. So using a key stakeholder analysis helps states organize the approach to partnership with each stakeholder. It provides a framework to look at for current partnerships and how they can be improved or maintained. And then for each stakeholder, the tool helps states consider what are their main motivations for the partnership, how they can best engage in the work, and who's the best person to ask for their support. And this is a tool that can be revisited as learning continues, as PDSAs continue, and states are learning more about their system and the strategies that they're employing. We also provide a spread planner, which is a framework for considering how your strategies can be taken to scale. So taking a strategy that's being tested at the local level and then spreading it countywide or statewide. This helps to consider multiple components of spread, including leadership, implementation, communication, partnerships, and measurement. We also have a health equity planner. And this is also a public document that you can reach, and Jenny has shared that link in the chat. The health equity planner is designed to be used throughout your improvement process. It helps states to consider health equity and social determinants of health. And it focuses on health equity across your work in the three main components of our CSN framework: child safety expertise, leadership and management, and systems improvement. It also allows teams to consider how they will assess their current situation, how they can plan, test, monitor, and revise or adapt their health equity work. And this is also a tool that can be used at the departmental level or at the programmatic and work unit level, or maybe in conjunction with the two. So we do encourage you to check out our health equity planner for this work. So that's an overview of our tools, our quality improvement tools, and how we use our tools in the CSLC. And I will hand this over to Erin to introduce our voices from the field. Thank you.
Thank you so much, Maria and Jenny, for walking us through all of these tools and the structure of the CSLC. It truly is the use of these tools that helps us as teams working together and as individual teams back in our own states to move our work forward. So I'm very excited to now bring in some voices from the field, and we're going to bring them on camera to have a conversation with them. Excuse me. So our first, I want to first welcome from Wisconsin, Judy Wendorf. Judy works with the Community Health Services at Children's Wisconsin. and is part of our bullying prevention topic team. And Judy's team is one of the newest to cohort 3 and is one of the newest that's joining us here today. And we'll be able to speak to how, even in a short amount of time, we can use these tools to get us started. So thank you for joining us, Judy. We also have we're so happy. From Florida, Corey Smith is joining us. Corey is the Suicide Prevention Coordinator for the Florida Department of Health Violence and Injury Prevention section. She's been part of the Suicide and Self-Harm Prevention topic team, and will be sharing with us how their team has used these tools to adapt and pivot throughout the process and their involvement throughout their involvement in the CSLC. Finally, we have with us from Nebraska, Jeannie Beast. Jeannie and her team from Nebraska work on the motor vehicle passenger safety team, and she works for the Nebraska Department of Health and Human Services Injury Prevention Program. Jeannie's team has been with us the longest and has had the opportunity to use the most of these tools in various settings with various programs and to various ends. So we welcome her and the great knowledge she brings. If anyone on the call today with our participants are current or former members of the CSLC, we'd also love to hear from you in the chat on your experiences with these tools. Joining me to help facilitate this conversation is my friend and colleague, Maria Cotradas. Maria, thank you for being here. So thank you all for being here. I'm excited to hear a little bit about you. What we're going to do is we're going to start here a little bit about everybody's story and then dig a little deeper into each of these tools. So I want to start with Judy. Judy, knowing that your team is new to the bullying prevention team, starting with this cohort in November of 2021, I wanted to ask you a little bit about how you have started to use the tools, some of the tools that Maria mentioned, obviously not all of them, but the ones that you have started to use and how they've impacted your work in adapting, changing, and improving your bullying prevention work.
Thanks again for having me, Erin. As you said, we've been here with the team about 6 months, and if you listen to a lot of the descriptors leading up to this part of the presentation, you hear them talk about small chunks and little bits and making tiny steps, and that's really critical to this whole process. So as we kind of jumped into all of this, we work with schools, and we know teachers are overwhelmed. We came in November. We know we only had until next May or June to engage this work with them. And so we've used the 90-day aims to really kind of help us hone in on what is it we really think we can accomplish in this school year. And then we've gone through one PDSA cycle already, and we are preparing to go through another one during the summer months as we collect some data from how schools did this past spring.
Judy, could you tell us a little bit about that PDSA cycle and how you landed on what change you were going to make and the process of using that tool or that model?
Sure. So our team has offered bully prevention courses in the kindergarten through 8th grade levels through schools throughout Wisconsin for well over 10 years. This year we created a short course, a cyberbullying course for high school. It's a whole different group for us to connect with, and initially we thought, well, maybe we could get 1,000 students in there. And when we launched the course last fall, we weren't getting that many. We weren't getting the registrations. We could tell we had fallen short. So our first PDSA was to look at how are we going to reach these educators that we don't have connection to. And the PDSA helped us think through what is it we know about what's working and what's not working, and where can we find out more information about this group of people. There are other groups within children's, and in fact kind of our sister team, if you will, in community health and outreach, community education and outreach that works with high schools. So we went to them and said, how do you do it? Tell us what you do. Tell us what works. And so they actually kind of told us about the campaign idea and getting high school kids to run a campaign. They shared with us an opportunity where they would do some warm introductions with some of the schools that they work with, so that then we could kind of have this kind of nice one-on-one opportunity to share this great resource and this new campaign that we're thinking about and get some feedback. And so that has led us to kind of getting into this audience that we have not worked with in the past. From there, we used kind of the 90-day aims again, because we were now looking at February and knowing, again, okay, we've got till June. How much can we bite off in this amount of time, knowing teachers are really overwhelmed, and what do we think they'd be able to accomplish? So when we looked at creating this campaign idea, we really honed in on how can we keep it simple, how can we get kids to deliver it, what's going to be kind of the carrot that's going to really kind of catch their eye. So through the PDSA and the 90-day aims, we've made some pretty good strides in a short amount of time.
That's fantastic. And what a great example of learning from your peers in a kind of an intra-agency way, and also doing those warm introductions, which are often so powerful, and thinking about your key stakeholders and your partners and how you can connect to them differently or more effectively. What a great example. So Judy really touched on that kind of 90-day aim and the PDSA. If you have any questions about how she used those tools or how those tools are used, any examples of your own use, feel free to just pop those in the chat, although I think I'm pointing in the wrong direction. Pop those in the chat, and we'd love to hear from you. I'm curious, Corey or Jeannie, if you wanted to share any examples that you had about using those tools in a similar way.
Sure, yeah, I can share. Thanks for having me here today. So we kind of went back and forth with how we use the tools. First, we started off looking at the change package and kind of looking at all of the partners that we originally worked with some other state agencies, and we kind of did like a pro and con of what we thought strategies would work best for, excuse me, for Florida. And so one of our partners that we're specifically working with, of course, was the Department of Education, and originally we saw that they were doing a lot of work around social emotional learning programs, and so with that it seemed like that strategy that was included in the change package would be the best one that we could spread throughout other counties that weren't using those programs already. And so after that, we thought we were ready to kind of move forward with figuring out how to measure that strategy. And so we looked at the operationalization form in order to do that. And then once we kind of used that to see how we could collect that data, and then we tried to break it down into a way that would be more manageable instead of like looking at the forest, kind of, so to speak. We use that 90-day aim worksheet to help us to make smaller action step items. And then at that point, when we were seeing all of our partners and stakeholders that were on our team, we kind of realized that the strategy that we originally picked from the change package didn't really make sense as far as what the school systems were using and how their district mental health plans were already established. And so by using that 90-day aim form, we were kind of able to kind of circle back and pick a more appropriate strategy for Florida.
That's great. What a great example of kind of using some of these tools to get to know your partners, learn who they are, and then and readjust. I mean, so much of quality improvement is, you know, oh, nope, let's adopt let's adapt, let's change. So using those tools to identify where something may or may not be working is really powerful, and I'm glad that that was able to work for you. Do either Judy or Jeannie want to jump in on kind of the use of the 90-day aim or the change package? And Corey spoke a lot about that use of that change package to look at what would be most impactful and most effective for Florida in addressing the issues of suicide and self-harm. Knowing that y'all are working on other topics, are there any ways that you've used that change package, the 90-day aim, or any of those similar tools to impact your work?
Well, here in Nebraska, we were fortunate enough to be able to actually get on the CSLC from the beginning of our teen driver initiatives, because we did not really have too much going on. And so over the years, we've used quite a few of these depending on, the situation we were in. And so it's really led our program to be really more robust, I believe, than what it would have had we not had these different types of tools. And it does start with the change package. We've used that to, kind of really identify what else we can be doing, but also say, hey, what we are doing is evidence-based, and it's right here, and it helps with upper management and things within our agency to say, this stuff works, but you got to give us time to get it to work. And so through that process, we've used the Plan, Do, Study, Act cycle. We've used the spread document, the AIM statement, and then the health equity one. The one we really like the most and use the most is the Plan, Do, Study, Act cycle. It really takes a large kind of topic or task, and for us it broke it down into smaller quality types of tasks to assure we were moving our programming in the right direction before we started spreading something around that wasn't very good. So for example, when we started the teen driver initiatives, we're like, what do we have for graduated driver's licensing besides the DMV that we know gets kids licensed? But it's more than that. Kids and parents need to know about what rules they have to abide by, and there was nothing. I mean, I read through so many pages of the internet on our own state website, and there was nothing. So we used a PDSA to start that process. And so you can use a PDSA to do a very simple task like creating material. So we took incremental steps from researching the information, did a PDSA around that, what will be in that document. You have to have stakeholder input. What does the graphic design look like? And from doing that PDSA and doing multiple ones, because we had a parent survey, a teen survey, a stakeholder survey to give guidance on what this document should look like, ended up creating a really nice piece of material that now we have in the spread phase of across the state. It's a standardized document of graduated driver's licensing restrictions, as well partnered with a parent-teen driving agreement that is spread to schools, law enforcement, driver's education, instructors, any other stakeholders across the state. They have free access to that. And so had we not gone through a PDSA and try to do kind of quality improvement with this materials, we would have thought, we know it all, we know what this says, and it wouldn't have been as good of a document it is now, because parents really questioned and gave us input on what does POP even mean? What does this mean? Well, why can't my kid drive after midnight? And we learned a lot through that process. So because of that PDSA, we were able to then use the spread of how we're going to spread this document and kind of make it something that everybody uses across the state.
Thank you, Jeannie. That's so much that you've done, and one of the things that you touched on that I love is this idea of using that PDSA cycle to do small tests of change and to apply it in multiple areas of your work, whether it's process or programmatic or the development of materials. I think you really used it in a broad number of ways. Maria, I think you had a question as well.
Yes, thanks so much. It's wonderful to hear all of these examples. So Judy, you mentioned a little bit about involving your audience, like the teenagers, of like why they're using or not using your online system. And Corey, you spoke a little bit about involving your key stakeholders in your work. And Jeannie, we know that you've been doing this as well. Could you speak a little bit more about that and let us know how you involved your partners or key stakeholders in your quality improvement work?
Sure. I can go first. So we initially, the partners that we were speaking with were the educators. So is this, we're thinking about this type of a campaign. Do you feel like this would work with the student groups that you mentor or that you help and work with? And then from there, we got positive feedback from them. So we stuck with our design. We've rolled it out. And now as part of the campaign, we're asking them to do a survey at the end. And so the survey includes questions of the kids who've implemented the campaign, asking them, what did you think about the campaign? What could we do different? How can we reach out to other schools and other educators to get this information into their hands as well? So we're asking some of the same questions of the students. We're asking those of our school champions as well to learn more about how we do and what do you think and what would make it even more impactful as we move into next fall.
Great. Thank you so much, Judy. Corey or Jeannie, could you speak to this a little bit more as well?
Well, with our PDSA, with our GDL materials, it was all about the partners. We have already established a Drive Smart Nebraska coalition. So through them, we had others look at our design. And, it didn't take like 100 people to like look at it and, revise it. It took like 5 parents to look at it and they're like, this is what needs to be changed. And then we had law enforcement look at it. We had a few, so that's the one thing too is what I've learned through this process is, this doesn't have to be a full-blown research kind of, reliability standard, study. It's just working with people that and really being genuine and wanting their feedback. And they're more than happy to provide it because we did a survey with parents asking about their knowledge even of GDL, and their knowledge is not where it should be. So that really showed us too, not only we're not just creating materials just to create them, but to really inform parents of how they can be better involved with their teen and open up the line of communication, because they really thought the parent-teen driving agreement was really nice to have with that, so they can sit down and have a discussion with their teen driver, so that the better the communication, the safer teen driver you're going to have when you have those expectations lined up. And along with that, we implement teens in the driver's seat in schools across the state, and there were like certain communities